Okay, ladies and gentlemen, without coffee we are going on and on because we are in delay, some 10 minutes delay. Next presentation is from Croatia, from Pula, beautiful region of Istria. Irena Hrstić is director of the General Hospital Pula. And the title, the topic of her presentation is the risk of HCC after SVR.
Good afternoon, everyone. My name is Irena Hrstić and I'm hepatologist currently working in General Hospital Pula. In the next 10 minutes, I will talk about risk of hepatocellular carcinoma in patients with hepatitis C after treatment. To be precise, I will try to answer the question, should we worry about HCC in patients who achieved sustained viral response? For better understanding why HCC unfortunately is still a problem, even in era of available successful treatment for chronic hepatitis C, it is good to repeat some known facts. Fibrosis in untreated individual progress from stage 0 up to stage 4, which is known liver cirrhosis. Liver cirrhosis usually develops 20 to maximum 30 years after initial infection. When in stage 4, disease can further progress toward disease decompensation or toward malignant transformation or HCC. HCC after SVR can present as de novo malignant disease or as a relapse. I will present the incidence data depending on treatment protocol. Was it interferon-based or DAA-based treatment protocol? Risk of HCC in patients with SVR after interferon protocols are very well known. In this table you can see the data from meta-analysis published 7 years ago. Patients are divided in two groups. All patients consist 25,000 data, and another group, patients with advanced fibrosis, data from 2,600 patients. It is seen from this table that those who have SVR have less incidence of HCC despite the fibrosis level, and it's also important to notice in this table that patients with SVR have also changed to have HCC, and the HCC is more incidence in those with advanced fibrosis compared to patients with small fibrosis. In this big retrospective cohort study, authors looked for a relationship between SVR and de novo HCC in post-treatment period. Data were collected from 62,000 patients who initiated antiviral treatment, and 58 of them received only interferon regimens, 7% of them received DAA and interferon protocols, and 35 of them received DAA-only regimens. Patients were followed for 6.1 years. Among more than 62,000 patients, author identified 3,271 incidence cases of HCC. The incidence was highest in patients with cirrhosis and treatment failure, followed by patients who had cirrhosis and achieved SVR, followed then by patients who hadn't any cirrhosis and had treatment failure, and the less incidence of HCC was in patients who hadn't any cirrhosis and achieved SVR. On this slide you can see comparison of HCC risk for patients on interferon and for patients on DAA treatment protocols. Looks of the graphs are similar for both group of patients, and it is possible to see that the patients with cirrhosis and no SVR has the highest incidence rate of HCC, and the patients with no cirrhosis and with SVR has the lowest chance to achieve HCC. This table shows that the risk for HCC is higher in patients receiving DAA agents compared with patients with other treatment groups, combined or interferon monotreatments. But when you look at the benefit of an SVR, it is very clear that SVR significantly decreased the risk of HCC. Risk reduction for patients treated with DAA and interferon are almost identical, 71 versus 68% risk reduction. Most likely reasons for higher incidence of HCC in DAA group of patients is the fact that with the DAA were treated sicker and older patients. So far, we know that the patients are in increased risk for HCC, but they have all the same risk despite the stage of the disease. We know from interferon studies, and in this slide you can see from retrospective cohort study from Japanese group of authors that the risk for HCC is more in patients with F4 and F3 liver fibrosis, and surprisingly it is even shown that the patients with F2 have some risk of developing the HCC. Regarding the fact that HCC is still a huge problem, scientific community is trying to find the models that can predict HCC accurately in patients with chronic hepatitis C. One of them is recently published Toronto HCC Risk Index. That index uses readily available clinical and laboratory parameters, has good predictive ability for HCC in patients with cirrhosis, and has been validated so far. Parameters are really very simple as patient age, patient gender, etiology of cirrhosis, and platelets count. From the table on the right, it is clear that the higher points are assigned to older patients and to those with underlying viral etiology. Patients are, according to assigned total score, divided into the low risk, medium risk, or high risk group with 10 years cumulative HCC incidence of 3, 10, and 32%. The risk score may help further to guide recommendation regarding HCC surveillance. Another model is slightly different and also published recently. It is free available on www.hccrisk.com. The aim of this tool is to estimate the 3 years risk of HCC in patients with hepatitis C virus infection who have undergone antiviral treatment. Data needed for calculation are values obtained before the initiation of HCV treatment. This risk calculator should not be used in patients with a previously diagnosed HCC, with the patient's prior liver transplant or cirrhosis from other etiologies, and this risk calculator has not been validated among patients without prior HCV treatment. For example, at this imaginary patient, which is female age 55 with cirrhosis and achieved SVR with genotype other than G3 with normal ALT and AST level, 3 years HCC risk is 3.07% per year. Diagnostic evaluation for HCC among patients with abnormal screening results should include either CT or MRI. From all the above mentioned, it is important to emphasize that the main risk reason for hepatocellular carcinoma is underlying liver cirrhosis. But since viral hepatitis C itself may have procarcinogenic potential, it is important to notice on this progression line that HCC can develop even earlier in F3 stage of the chronic disease. In clinical practice, that means that to calculate the risk of potential development of HCC, it is very important to know at what stage is chronic hepatitis C in an individual, despite the fact if the individual is untreated or treated and cured. At the end, I will say just a few sentences about HCC and COVID-19 pandemic period. Measures for the care of patients with liver disease during the COVID-19 pandemic era have recently been proposed by EASL. Patients who have chronic liver disease and HCC and who are COVID-19 positive should be admitted for inpatient care. Slightly different approaches for outpatient clinics. Patients are divided in 3 priority groups: high, medium, and low priority. In high priority groups are those with decompensated liver disease, those awaiting for liver transplantation, those with suspected HCC, those with proven HCC awaiting treatment initiation, and those with moderate or severe side effects to treatment. Medium group presents patients with HCC suspected lesion less than 1 centimeter, patients who have response and tolerability to treatment, and those with mild effects to treatment, and those in a need for second opinion. Low priority patients are those who are in long-term remission more than 5 years, and patients in end-stage HCC without any options for recompensation of liver function. Priorities for HCC imaging are also divided in high, medium, and low priority. In high priority are patients who are in need for a workup of HCC suspected lesions and patients with decompensation of liver function. In medium priority are patients with suspected liver lesions less than 1 centimeter without progression, and in a low priority are those who are in a regular HCC surveillance. To conclude, at the end, HCC can develop even in patients with SVR, especially in those with liver cirrhosis. Recommendation for HCC screening after SVR, according to AASLD, IDSA, and EASL, are divided in 2 groups. Patients with F0 to F2 fibrosis do not need any regular surveillance, while patients with F3 and F4 fibrosis need ultrasound surveillance every 6 months. Thank you very much for your attention.
Thank you very much to our Dr. Irena Hrstic. And now, ladies and gentlemen, live from Italy, from Humanitas Research Hospital, Razzano, Chairman of EASL, International Liver Foundation, Professor Massimo Colombo. Massimo, hello, are you prepared?
Can you upload the presentation?
Sorry?
Yes.
Do you upload the presentation?
Yes.
Yesterday I dealt with your technician.
Okay, okay. Just a second. Okay, we need another more seconds.
Because we were unable to have the sound recorded presentation
Okay.
uploaded.
We need just a minute. Okay, we'll try to solve our technical problems. Okay. Okay, we will solve this. Nevertheless, maybe Tatiana, you want to say something in this small break?
Yes,
you
thank
want to
you.
say something? What is?
Good afternoon, Tatiana.
Hello, Massimo. I think that our technicians understood, Massimo, you would have to share your presentation.
No problem, I can do it now. Sorry,
Yes,
because
please.
I worked yesterday with your technician because we were unable to have the sound record. There were technical issues, I think, and I'm so sorry. Otherwise, I can. Okay.
Thank you so much. Because if it is from here, then you will not see it.
Okay.
Do you need time?
So I have to leave for a while.
Okay. Because we have a pre-recorded presentation, maybe. Okay. Okay.
So, can I go sharing my own?
Yes. Thank you very much.
Share screen.
Yes.
You get it?
Open. Yes, but you need to open the presentation.
Oh, come on. Where is this? This one.
Okay. Yes. Perfect. Start
You get it?
presentation.
You got it?
Yes, but you need to open. Open. Okay.
You mean this way?
Yes.
Shall I go?
Yes.
Okay. Thank you. Okay, good afternoon. Sorry for this misunderstanding. Here are my conflicts. We heard that hepatitis C is a relevant cause of liver disease, globally speaking, with a special emphasis on the risk of developing
Professor
cancer. Here's a
Colombo, we
study
have to
done
stop. Professor
in the
Colombo,
past
sorry.
20 years in type 1, the so-called REVEAL study that highlighted
Professor
the high
Colombo.
risk of developing cancer for carriers of hepatitis C, whereas there are also evidence of additional liver complications. Most of them were extrahepatic. In a recent modeling study by Dr. Razavi, it has been predicted that every year we are going to face the risk of more than 180,000 incident cases of liver cancer globally that account for more than 150,000 related deaths. This explains the attention that is paid on treating this complication through antiviral therapy, on the assumption that removal of the virus would account for a clinical benefit, including a reduction of the risk of liver-related mortality. And WHO has launched a program whereby by 2030, we predict having a decline in the incidence of liver cell cancer through elimination of viral hepatitis C, which in parallel will account for a decline in liver-related mortality. It has been long said that the risk of developing cancer is linked to the trend of the infection to generate and accumulate fibrosis and develop into cirrhosis. Here is something at variance. Is a study done by Dr. Lemon in America.
Massimo, do you hear me? Tatiana is here. Please, can you double click because we do not see your slides. Can you please double click on the HCC Croatia June 2020 PowerPoint presentation on your screen because we do not see your slides.
Okay, this is my slides. Where should I double click? Here?
On your presentation, on the presentation.
Yeah, here is my presentation.
We do not see the
I
slides.
share it. You are screen sharing live here.
You see the last one presentation, the last presentation. Can you double click on it so that we can see your slides? The presentation titled HCC Croatia June 2020 copy.
I don't know why, but I think that it has been blocked. Let's see. This is the title of my presentation.
Professor Colombo, please,
Si.
we will continue with the next presentation. I will call you on the phone and we will get everything ready for your presentation after this next one. Is that okay with you?
Why not?
Perfect. Okay,
Okay. Professor Colombo, you occupied our screen.
Can you please exit from the shared screen, please? Thank you.
Stop share.
Thank you. We will
Okay.
solve this problem. Okay, we will do and hear and see our next presentation because of the technical problems. We pre-recorded a lot of presentation. Next presenter is Grit Hendricks from Belgium, member of Scientific Secretariat of the Viral Hepatitis Prevention Board, and the title of the presentation is Hepatitis B Innovation in Prevention Measures as part of Integrated Care. Tough word without coffee. Okay, let's go. We are prepared and cross
Hello,
fingers for
everybody.
Professor Colombo.
Let me first start to thank the organizers for giving the opportunity to represent or to present the Viral Hepatitis Prevention Board and to give an overview of the challenges that we think hepatitis B vaccination will get in the future. These are my conflict of interest that are mainly linked to the fact that I'm working for the Viral Hepatitis Prevention Board for the University of Antwerp. So the VHPB, or the Viral Hepatitis Prevention Board, is an expert board that exists already for more than 27 years. The main mission of this board is to contribute to the control of and the prevention of viral hepatitis by drawing the attention to this very important public health problem. Our focus audience is, in first instance, opinion leaders, policymakers, public health professionals, and healthcare professionals. So normally in a year we organize at least 2 meetings. It can be a technical meeting or a country meeting where we bring together the hepatitis experts of the country or related to the topic that we would like to discuss. And we bring them together with our expert from our advisors board. The experts in our advisor board come from international organizations like WHO, ECDC, the Global Task Force, EASL, and the patient organization ELPA, but also from public health institutions from different European countries. Also experts coming from academia, different universities in Europe, are members of the board and covers the different specialisms of hepatitis. The board is located in the Centrum for Evaluation of Vaccination in the University of Antwerp and is led by Pierre van Damme. Together with 5 other colleagues, we are running the Secretariat of the Viral Hepatitis Prevention Board, but also of the Human Papilloma Prevention Board. If you would like to know more on the board and the activities of the board, I invite you to visit our website as it is mentioned over here. Since hepatitis B vaccination is one of the most effective prevention intervention, we thought that in a meeting where the focus is mostly on treatment, it would be a good idea to present the future challenges of hepatitis B vaccination. Hepatitis B vaccine is used for more than 35 years. And as you can see, in this Bulgarian study, it really has an impact on the HBs antigen prevalence after the introduction of universal vaccination. The same effect was measured after the introduction of birth dose vaccination in China. Besides the impact on the incidence of hepatitis B, also the impact on the disease was proven, as you can see in this study, where the impact on hepatocellular carcinoma as well as in liver disease as a whole was measured. So if the impact is proven, do we still need to talk about hepatitis B vaccination, or can we end here the presentation? But although this long-time use of hepatitis B vaccine, and partly due to the change in epidemiology by the wave of new migrants entering Europe and coming from high endemic countries, there is still a substantial burden of disease. Even in Europe, as shown in this recent ECDC report, where the countries in brown and orange still have an incidence of more than 0.5 acute hepatitis cases per 100,000. Therefore, it is important to keep the focus also on hepatitis B vaccinations. What are the challenges for hepatitis B vaccination? As first challenge, it is important to increase or to at least keep the high coverage rate of hepatitis B in a country. If the coverage rate of the third dose of hepatitis B is compared among the different WHO regions, it is clear that in Europe, the blue line, there is still a margin to grow, especially in those countries with a coverage rate lower than 95%. But it's also important to keep this high coverage rate. As you can see in the analysis that in 2014 there were 26 countries with a coverage rate above 95%, but in 2017 6 countries lost this good coverage rate. The next challenge we would like to discuss is the evaluation of the current vaccination strategy in the country. Ideally, there should be a combination of universal and risk group vaccination. For universal vaccination, WHO recommends birth dose vaccination. Most countries that implemented the birth dose vaccination have high coverage rates. The low endemic Western countries that did not implement birth dose vaccination but choose for screening of their pregnant women should evaluate the effectiveness of their screening program and especially the follow-up of the babies and the positive mothers. And last but not least, we would like to discuss an important challenge we all face in the vaccine world, vaccine hesitancy or the lack in vaccine confidence. Especially in these pandemic times, because it's already proven that COVID has a negative impact on the vaccination coverage, as you can see in this study from CDC. And in the UK, as you can see here, but not only on the vaccine coverage. Although a COVID vaccine will be the only effective measure to control the pandemic, it goes very high expectation. And contradictory, it results in an increase of anti-vaccine messages that are fast circulating on social media and have a negative impact on the vaccine confidence. When analyzing posts on Facebook, it becomes clear that the anti-vaxxers, the red dots, have a broad network and reach more undecided people, the green one, while pro-vaccines, the blue ones, are isolated and their message don't reach the people who are still undecided, neither the anti-vaxxers. So although there are a lot of campaigns developed, they don't reach the target group. Therefore, it is very important to train healthcare workers, GP, nurses, midwives, not only to improve their knowledge, but also to improve their communication skills so that they may answer to the vaccine concerns of their patients. Additionally, governments should defend their immunization program and communicate professionally about vaccines, especially when vaccine crisis pops up. In conclusion of this presentation, we hope that we could convince you that it is important in this area of effective treatment that elimination of hepatitis is only possible if you also pay attention on prevention programs, including hepatitis B vaccination. Therefore, we hope that when a country develops or is developing a national plan, it includes also vaccination targets with attention for the evaluation of their current vaccination strategy, including the vaccination of the general population and risk groups. Additionally, it is also important to create sustainable support of existing hepatitis B vaccination policies and programs and foresee an effective action plan in case a vaccine hesitancy crisis would pop up. Finally, we may say that there is still a long way to go, but we are on the right track to eliminate hepatitis. Thank you for your attention.
Thank you to Mrs. Hendricks, and ladies and gentlemen from Belgium, we are going to Portugal. In Portugal is Mr. Luís Mendao. Mr. Mendao is co-chair of ACHIEVE, and the topic and title of his presentation is Political Influence in EU, Why is Important? EU Policy Consideration, Building an EU Action Plan to Drive Forward the Elimination of Viral Hepatitis by 2030. Okay, in a few seconds, let's go.
Dear all, dear friends, my name is Luís Mendão, and I'm addressing you as the current co-chair of the ACHIEVE Coalition, but I'm also addressing you as an hepatitis C patient and a person who injected drugs in the past. I thank you, and especially my resilient friend Tatiana, for the opportunity to speak in this very important conference. ACHIEVE stands for associations collaborating on hepatitis, immunization and elimination of these viruses in Europe. I'm sorry that I cannot be with you on beautiful Croatia due to the restrictions of the COVID-19 pandemic. However, I'm grateful to the opportunity that modern technologies that allow me to pre-record this contribution for your discussion. Comparing COVID-19 to viral hepatitis, we can say that the fight against viral hepatitis profits from two important tools that scientists across the world are desperately looking to fight corona. In viral hepatitis, we have an effective vaccine for hepatitis B and a very easy and cure for hepatitis C. Of course, we would be in a better situation if we also had a vaccine for hepatitis C and a cure for hepatitis B that I will think that we'll have in the future. However, just with the medical tools available now, hepatitis B and hepatitis C can be eliminated as a public health important problem. That's why the WHO Global Strategy on Hepatitis from 2016 and WHO Action Plan for Europe from 2017 made clear that elimination is a feasible target by 2013. What we think is missing in viral hepatitis fight is the political will, adequate investment and impetus to monitor better the progress of hepatitis elimination in line with the European indicators developed by ECDC. It's also missing a better integration of viral hepatitis in European Union and global funding programs in order to make sure that elimination will be a reality by 2013. Currently in Europe, sadly, we are very far away from this target. Latest data published in May by ECDC highlights that hepatitis mortality is too high in the region and shows very little evidence of progress towards the target of 65% reduction in mortality against the baseline data from 2015. The ACHIEVE Coalition brings together the different stakeholders which represent patients, most at-risk groups like people using drugs, researchers and clinicians, to jointly advocate for more political and policy support from the European Union. It would be a shame if the European Union let herself behind on these objectives. Last December, ACHIEVE had a workshop in Brussels to create consensus on the needed European Union focus on this new legislature. The meeting was attended by ECDC, WHO, the Foundation for Innovative New Diagnostics, and the Spanish Ministry of Health. We were also happy to receive contributions from the International Office for Migrations, the Global Network of Parliamentarians to End Infectious Disease, and the European Commission. There is a report of the new workshop in our website for those of you who would like to see it. Our main recommendations are to monitor better the progress of viral hepatitis elimination in line with the indicators developed under the leadership of ECDC. And allow me to say that without reliable and comparable data, it will be impossible to make this monitorization. We are flying blind if we don't invest in getting good data. We also recommend better integration of hepatitis in the European Union and global funding program, so we can exploit synergies, prioritizing overlap risk groups when seeking to identify those who are still unaware of having hepatitis B or C, that are, allow me to say, the vast majority. This is particularly important in times when public resources are scarce. I would like to highlight, in view of the policy developments since last December, our recommendation that says European Beating Cancer Plan should recognize not only the importance of hepatitis C immunization, but also the importance of improved diagnosis and linkage to care for hepatitis B and C, and better awareness of prevention and protection from transmission. In other words, if we want to prevent liver cancer, we must take care of vaccination children and other at-risk adults against hepatitis B, but we also must ensure that greater efforts are being made to promptly diagnose people with hepatitis C and B and treat them in order to avoid the liver cancer. Finally, Europe must ensure that people are aware of the transmission risks so they can take precautions. Prevention is always the best solution. Last February, the International Agency on Research Against Cancer published an article in The Lancet on the global burden of cancer due to infectious disease, which includes hepatitis B and C. In this context, the authors refer to the WHO objectives, saying, and I quote, "There is a critical need for resources directly towards cancer prevention programs that target infection, particularly in high-risk populations. Such intervention can reduce sharply the increased cancer burden and the associated mortality." As you can imagine, the Achieve Coalition is fully supportive of these arguments made by the International Agency on Research Against Cancer. However, currently, the European Union policies to prevent cancer only mention vaccination against hepatitis B and fail to make and to take into account the larger picture that I have just described. This gap is also present in the current European Code Against Cancer recommendations to lower cancer risks. Same gap is present in the initial roadmap for Europe Beating Cancer Plan that the European Union published in February. Achieve and I very much hope that the European Commission Cancer Plan that is due for publication in early 2021 will address the need to eliminate viral hepatitis also in the context of liver cancer prevention. A chief coalition also hopes that the hepatitis elimination will be part of the European Union commitment to the United Nations Sustainable Development Goals in the new European Union Health Programme. This is critical. We finally hope that the national cancer societies and all those working in cancer prevention support us in conveying this message to the European Commission and the future EU Council conclusions. We need to prevent suffering of people, and whenever we can, suffering and death. If we ensure elimination of viral hepatitis in Europe, we would contribute greatly to this very important goal. Thank you.
Thank you to Mr. Mendao. From Portugal, ladies and gentlemen, we are going back to Italy to Professor Massimo Colombo. Professor Colombo, we will play the presentation. Can you hear us?
Okay, thank you so much. I think that now it works.
Okay.
Here we are. Next slide, please.
Okay.
Next. Thank you. Okay. As we said previously, the hepatitis C virus has been recognized as a human carcinogen by the ERC agency in the late 90s based on a number of epidemiological, clinical, and experimental investigations. Here is the REVEAL study which was carried out in Taiwan on a cohort of patients that was prospectively recruited for hepatitis B investigations and was retrospectively analyzed for hepatitis C. And what they found was the carriers of hepatitis C had a 21-fold increased risk of developing cancer over a 10-year period compared to the negative patients. And they also were able to highlight that the virus can also cause extrahepatic liver and non-liver extrahepatic diseases, both malignant and non-malignant. In a recent modeling study by Dr. Razawi, it has been said that every year more than 180,000 incident cases of cancer develop in the world, causing 150,000 related deaths at least. Next slide, please. And this led the WHO to, next slide, please. And this led the WHO to call for a program of viral hepatitis elimination aiming at reducing the burden of cancer, which in parallel might also translate in a reduction of liver-related mortality by 2030. Next slide, please. It has been long said that the risk of developing cancer in patients with chronic hepatitis C is related to the development of progressive liver disease. But this is only partially true. There is, in fact, enough data to say that the virus itself is carcinogenic without passing through the phase of liver disease, because the genome of the virus, both in the core and in envelope portion of the genome, code for a number of proteins that are able to hijack the molecular pathways that control the cycle of liver cells. And this accounts for the onset of liver cancer in patients devoid of significant fibrosis, not to speak about cirrhosis. Next slide, please. This notwithstanding, we are quite convinced that the risk of developing cancer can be accelerated in certain patients independent of the carcinogenic activity of the virus due to a number of, let's say, variables that span from host characteristics like male sex or aging to the presence of a particular genotype of infecting virus, the genotype 3. We currently hesitated in thinking that this virus is particularly aggressive on its own. Perhaps genotype 3 in America and Europe identify people exposed to multiple cofactors like alcohol, drug injection, and other viruses. Not to speak to the co-occurrence of comorbidities related to metabolic syndrome. Diabetes is the most important clinical phenotypes. Not included here is analysis of the risk of alcohol, but this is a special study done at the Veteran Affairs in America, where the cohort is skewed towards men with a number of comorbidities, including alcohol. And alcohol is appear here as a cofactor of liver cancer, but elsewhere in other cohorts, it has an important role. Next. Not surprising, therefore, studies that aim to remove the virus from the infected populations could demonstrate a significant decline in the risk of developing cancer. And this is the case of this meta-analysis that agglutinates 59 studies done with interferon, where the decline of the risk of developing cancer was in the range of 80% and was paralleled by a similar decrease in the risk of all-cause mortality. However, data generated with interferon should be taken cautiously because interferon is a difficult to deliver medication. It exerts some kind of toxicities. There are issues of a patient's compliance and adherence to the schemes. And all in all, it cannot be offered to patients with advanced liver disease or an history of decompensation. So this is a special section or share of infected population, those with advanced liver disease, but very well compensated liver status. Next slide, please. The advent of direct agents against hepatitis C revolutionized the scenario of therapy because DAA were to be applied also to patients with fairly advanced liver disease, including decompensated. And this is again the Veteran Affairs study that demonstrated decline from 3.5 to 0.9 incidence of liver cancer per 100 persons per year. And the most important information coming from all these studies is that removal of the virus causes a significant decline in the risk of developing cancer, but does not eradicate the risk of developing cancer at this state for many years on. Next slide, please. What is important to mention, and that's the probability of achieve a decline in the hepatocellular carcinoma risk is inversely correlated with the severity of the underlying liver disease. This is the post-hoc analysis demonstrated that patients without cirrhosis had a stronger and more intense decline in the risk. And this is true also when you stratify your patients using non-invasive tests of liver disease severity like FIB4. And you see here that the risk of developing cancer after achieving SVR is inversely proportional with liver disease severity. Next. In the same setting of patients, another investigator, another she, the first one was Canwal, this one is Bacchus, demonstrate again, like it was the case for the interferon studies, that the decline of the risk of liver cancer is associated with a similar decline in the risk of all-cause mortality. And this drives you to these conclusions that cancer is in fact one of the most important risk factors of death in patients who are chronically infected with hepatitis C. Next slide, please. But can you go backward? One slide, please. Backward. Back. One slide back. Okay. But the important message stemming from all this study is that in order to achieve the eradication of hepatitis C virus in the infected population, you have to start treating patients early during the infection. If you target patients in the late phase of their disease, when the liver has already decompensated or has a history already of previous decompensation for any reason, then the probability of achieving a sustained virological response decreases in parallel. And here they showed in this study, the Brits showed clearly that the risk of failing virus eradication is greater for patients with the history of the compensation, and actually is even greater in those with the compensated liver disease, and even more so in the subset of patients who are infected with the genotype 3 of hepatitis C virus. So the general message is that the earlier the onset of therapy, the higher the chances of achieving virus hepatitis C eradication. Next slide, please. Next slide, please. It has been alluded to the fact that in the very beginning, the swift removal of the hepatitis C virus using DAA was associated with the risk of an early onset of liver cancer, which proved to be particularly aggressive, presenting as a multinodular cancer with an early propensity to invade the portal system. Subsequent studies was done here in Europe and in America that demonstrated that the risk of early onset of liver cancer is associated with the presence of nodules in the liver at the start of therapy. This is a study done in Milano by our group, Dr. San Giovanni, that clearly demonstrates. Hello?
We hear you.
What's wrong? I can't.
Just go on.
Mi ha bloccato la lettura. Che problema, com'è possibile?
Professor Colombo, we hear you, we can hear you. Just
I have to reconnect perché why the top? Yeah. Yeah. Okay. Can you hear me now?
yes, you can
Sorry.
continue. Okay.
So this is the study done in Milano where a subset of patients showed early onset of liver cancer after SVR, but that occurred only in the subset of population who showed undefined non-malignant liver nodules prior to starting therapy. So this led to the generation of a strong recommendation that prior to starting therapy in patients with chronic hepatitis C, you should investigate through an MRI that the patient is devoid of any suspicious liver nodules in the liver. As you see here, the difference with the rest of the population that had no such an early onset of liver cancer. Next slide. This study goes in parallel with an observation done in Spain by the group in Barcelona. Actually, it was a multi-center study, that one, that showed the increased risk of developing liver cancer early on after achieving SVR that was limited, restricted to those patients who had MRI or CT scan showed small nodules in the liver that were not defined as tumor because they lacked either wash in or wash out during investigation, but that in essence were early cancer that full blew upon removal of the virus. Next slide, please. The important message coming from all these studies going backward to the interferon era is that the risk of developing liver cancer stays lifelong in patients after a cure with either interferon or more recently with DAA. This is a study we did in Milano, and here it shows that the 20 years after achieving a cure, there was still a significant number of patients developing liver cancer. If you wish, this happened at the rate of 1.2% patients per year, but this is significant. And this happened also in patients who started therapy without having any significant fibrosis. So the current message is that patients after an SVR should be taken to periodic surveillance with abdominal ultrasound. Next. And this is exactly what they recommend the scientific association. What I personally disagree is that it is safe not to screen patients who start therapy with the DAA having no or little fibrosis in their liver, because these patients still face the risk of developing cancer after several years of from an SVR. So it's a matter of cost effectiveness, the reason why the society decided to focus only on patients with pre-cirrhotic changes in the liver, METAVIR-F3, or full-blown cirrhosis. For the sake of cost effectiveness, 6-monthly ultrasound surveillance is recommended in this specific population. I would say that even though it is not cost effective, it is effective screening patients who start therapy without having any significant fibrosis in the liver. Next slide, please. And this is what you asked me to present, some data regarding COVID-19. This is an investigation led by the European Association for the Study of the Liver in many centers in Europe. It has been recently presented in a webinar by Professor Thomas Berg. Okay, if your patient has chronic hepatitis C and gets an infection with COVID-19, the risk of dying is quite limited, 7%. But and this is a study done in 200 persons. In a 200 person with cirrhosis, the risk of dying was significantly higher, fivefold greater upon arrival of COVID. Interestingly enough, the risk of dying for patients with the liver transplantation was in between, it was rather limited. So apparently, infection with COVID-19 has not been as disastrous as the infection with SARS-CoV-2 for patients with liver transplantation, because you can manage quite easily reducing immune suppression. And as recently published by Dr. Mazzaferro in Milano, they had only 3 cases of patients of death related to pneumonia, and the rest of 45 patients went uneventfully upon reduction of immunosuppressant therapies. Next slide, please. Unfortunately, the outbreak and the pandemic of COVID-19 has led the liver community to suffer a number of restrictions. This is a study done in Italy, is a multi-center investigation of the Italian Society of the Liver, where you can appreciate that 60% of the hospital in my place had restricted delivery of services, including hospitalization rates, access to liver transplantation, care of patients with liver cancer, providing limited providing of endoscopic services to bleeding patients here and there. And all these restrictions were the consequence of the huge demand to expand ventilation capacity for the COVID-19 patients that led to an obvious shortage of availability of the support by the anesthetics. And at the same time, there has been a huge recruitment of nurses and physicians from all the specialties to implement the assistance of the COVID-19 infected population. That led, of course, not only to a, let's say, deferral of elective surgeries and elective intervention for liver patients, but also to the implementation of telemedicine to deal and to manage out clinic patients during the phase of the pandemic. And with this, I am finishing, and I thank you for your attention.
Thank you very much, Professor Colombo. Ladies and gentlemen, dear participants, we are going to Spain, to the head of the health system team at Barcelona Institute for Global Health, to Professor Jeffrey Lazarus. Professor Lazarus will talk about importance of monitoring system to measure progress on elimination along the cascade of care.
Thank you very much to Hepatos for this invitation to speak at this important meeting on liver cancer prevention. I will be specifically addressing hepatitis C, one of the major causes of HCC, and the important need for monitoring. My name is Jeff Lazarus. I'm a professor at the Barcelona Institute for Global Health, and I'm the vice chair of the EASL International Liver Foundation. Now, a couple of questions for us to think about. Firstly, do you believe that the elimination of hepatitis C as a major public health threat by 2030 is possible globally? And what about here in the European Union? What about for specific populations, the microelimination approach that I'll be discussing in a moment? And importantly, how will we know if we've achieved elimination? So we do know that viral hepatitis is the 7th leading cause of death in the world. And the Lancet GastroHep Viral Hepatitis Elimination Commission that came out last year was able to report on both hepatitis B and hepatitis C prevalence from around the world. And here you have some of the data from some of the European countries. And what we found working on that commission was that it was extremely difficult to acquire accurate prevalence data. So it's extremely important that EU countries get better at diagnosing people living with hepatitis C, because in some countries it's the majority that are estimated to remain undiagnosed at this point in time. Now, there was a major turning point, which you're all aware of, in 2016, when the World Health Organization published its first global strategy aiming for the elimination of viral hepatitis as a public health threat, as they put it, by the year 2030. And how are we going to do that? WHO put forward a series of targets that you see here, some which should be achieved by this year, 2020, on incidence and mortality and harm reduction, and others by 2030 with testing targets and treatment targets. Importantly, all of these targets took 2015 as a baseline, a period of time when we actually don't have strong baseline data. So that already complicates the monitoring process in terms of being able to compare where we are now with where we were in order to monitor progress towards hepatitis C elimination. WHO also put forward a continuum of viral hepatitis services, also known as the retention cascade or the continuum of care cascade. It starts with the estimation of all infected with hepatitis C and then moves from testing and diagnosis through to viral load suppressed or sustained virologic response, and finally follow-up and chronic care, which is very difficult, of course, to monitor and needs to be collected at the hospital and clinic level and then reported nationally. Many countries have found it difficult to report along all points of the continuum of care, and this lack of standardization in HCV cascade of care monitoring hampers efforts to report progress towards WHO elimination targets. Here is some data from Australia, which has a very strong surveillance system. Quite accurate figures are thought to be reported here. In the EU, countries as diverse as Bulgaria and Denmark have not even been able to estimate the prevalence of people living with hepatitis C, although some countries like Denmark are able to very accurately report those treated. WHO also recognized the importance of limiting the number of points to report on the COC, and this is back in 2015 when they were reporting global estimates of infected. They thought it was around 71 million people based on data provided by the Polaris Observatory, a huge drop-off to the numbers diagnosed, and at that time very few people were started on treatment and they did not report the numbers of cures. Now, with that in mind, a group of us from around the world decided to develop a consensus hepatitis C cascade of care in order to simplify monitoring. It starts with having the numbers infected, then diagnosed, treated, and cured. And the hope is that all countries around the world will, at a minimum, report these 4 points along the continuum of care. And I think this is a priority for EU countries to make sure that all countries are able to report these figures. Here you see the consensus cascade of care applied to Sweden, with a small drop-off from the numbers of infected to diagnosed and a rather large fall to the numbers treated, with most of those treated being cured. If this were Denmark, you would see a much lower number diagnosed, but most of those diagnosed treated, and almost all of those treated cured. So this makes the consensus COC a very useful tool for comparison among countries and within countries over time. In addition to the numbers, it's also important to monitor the hepatitis C elimination policies that are in place. The Lancet GastroHep Commission that I mentioned earlier did this for more than 60 countries, and here you can see the key policy in terms of data, prevention of transmission, screening, and treatment that are needed to eliminate hepatitis C. Some countries doing better than others, some regions doing better than others. If you look, for example, at not having a national plan or strategy, you'll see that Europe is doing relatively well compared to, for example, the Middle East. In terms of mandatory screening of donated blood, you'll see that all countries report doing this. On the other hand, having DAAs available for free is not the case in most countries. We need to revisit this year on year and see how countries are putting key policies into place. But importantly, we need to also look at, are they actually implementing them, not only at the national level, but at subnational level. Another important issue to monitor is late presentation of chronic viral hepatitis B and C. So late presentation is a problem both for the individuals presenting late, i.e. with advanced fibrosis, but also for the health system, which then has a greater challenge in treating and curing those individuals. We developed a tracking tool that I'd be glad to share, and we're carrying this out in Spain and in a number of other countries to see how many people are presenting, or rather getting diagnosed late with hepatitis B and with hepatitis C at the hospital and clinic level, in order to make some estimates also at the national level. In addition to national monitoring, we need to make sure that we're monitoring at the hospital and clinic level, but also other settings where hepatitis C will be diagnosed or treated, such as drug and alcohol clinics, GP centers, prisons, harm reduction services, and community health centers. Now, I mentioned earlier microelimination. This is an approach that focuses on certain populations or subnational geographies in order to eliminate, or rather microeliminate, in that particular setting or population. Some populations are going to be easier to reach because they're mostly diagnosed and in care, like decompensated cirrhotics, patients with hemophilia, patients with chronic kidney disease, and transplant patients. Other populations are harder to reach, like those who inject drugs. And while prisoners are not necessarily hard to reach, since their health services are governed by the Ministry of Justice, hepatitis C may not be a priority. Now, the microelimination approach was developed by the EASL International Liver Foundation a few years ago, at the time of the launch of the Global Health Sector Strategy on viral hepatitis by WHO. Many countries thought it was complex and challenging to eliminate, and the EASL International Liver Foundation said, let's break down the entire population with hepatitis C into smaller groups and make a plan for how to eliminate in that population, set annual targets in line with the WHO strategy and action plan for elimination, that this should involve a multi-stakeholder process with essential participants, including government officials, health service providers, and civil society representatives. And importantly, microelimination approaches should monitor progress and outcomes and publicly report the findings. Now, if we have strong monitoring in place, this will also help us make strong estimates. Last year, just a handful of countries were reported to be on target to eliminate hepatitis C by 2030 as set out by WHO, and among those only 3 were in the EU: Spain, France, and Italy, closely followed by Austria, Germany, and Malta. New data will show slight improvements. It will be presented at the International Liver Congress, the virtual Congress, in August. But what we really need to see is all EU countries in the green on target to eliminate hepatitis C by 2030. And given the resources available in the European Union, many countries have already, and more countries should seek to eliminate hepatitis C already by 2025 or even. So as we put everything together to achieve hepatitis C elimination, an important step in liver cancer prevention, we need to make sure that policy leaders are involved, healthcare providers, civil society, academia, industry, and other stakeholders. And that's why this meeting today is so important, because it brings together this diverse set of stakeholders. So I'd like to thank again the Croatian presidency for prioritizing this issue, to Hepatos for the invitation to be here, and to all of you for taking time out of your busy schedules during the COVID-19 pandemic to think about how we can eliminate hepatitis C and how we can prevent liver cancer. I'd also like to acknowledge my co-authors, all of the authors of the cited studies, and thank in particular the EASL International Liver Foundation for the work they've carried out on microelimination. Thank you.
Thank you, Professor Lazarus. Ladies and gentlemen, we are going to Georgia, to Amiran Gemkrelidze, the Director General of National Center for Disease Control and Public Health. Mr. Gemkrelidze will talking about best practice, next phase of Georgian Elimination Plan HCV, attributable HCC.
Dear Chair, dear participants, I would like to welcome, on behalf of National Center for Disease Control and Public Health of Georgia, to the participants of the Hepatos scientific meeting with political goal. It's a great pleasure for me to participate in this distance conference, and I will give you a short overview of the Georgian experience, next phase of the Georgian Elimination Strategic Plan on HCV, attributable to HCC. Georgia is one of the countries implementing the hepatitis C elimination program. This program started in the country in 2015, and our major partners are the CDC Atlanta and the Gilead Sciences. Through the support of these 2 major American organizations, we implemented last 5 years in Georgia, and we are very proud to have this one of the most, the valuable and most important program, public health program, HCV elimination. Everything started with seroprevalence survey, to know what's the background figures regarding the HCV prevalence in the country. Previously, we had some observational study, but the classical seroprevalence survey we provided in 2015, and total number of interviews was 6,330 randomly selected persons in all adults in all regions of Georgia. 90% we had a response rate, and total number of blood samples was collected 6,010. Response rate 86%. And we found that the prevalence of the antibody positives in this randomly selected, the group, was the 7.7%, and RNA positivity rate, the chronic infection, HCV infection, was found in 5.4% of adults, which in absolute figures is around 150,000 adults Georgian infected by hepatitis C virus. And genotype distribution is like this, what's on the right side of the slide. I mean, the leading genotype is genotype 1b with 39%, then comes genotype 3, 34%, and then genotype 2, 25%. Main risk factors for the transmission of the infection in Georgia is the intravenous drug use and history of the blood transfusion. Together with CDC Atlanta, we have created a strategic action plan for 2016-2020 with, I mean, the quite ambitious goals, 90, 95, 95%, which means that we have to investigate 90% of all, I mean, the HCV affected persons in the country, which is 135,000. 95% should be diagnosed and treated, and 95% should be cured. The action plan has 6 major blocks, like the awareness of the disease, prevent the transmission, identify persons infected with HCV, improve HCV laboratory diagnostics, provide HCV care and treatment, and improve HCV surveillance. Here on this slide, I'd like to show the summary of 2 main directions and what we achieved. First of all, this is the universal screening, what we are providing in the country. And we have a unified screening register in the country where we have currently 3.9 million screening tests. Of course, some tests for some persons are made twice, 2, 3, 4 times. And the unique persons here are 2.2 millions. Among those 1.9 millions are adults. And our goal is to investigate all adults, 2.8 millions. Positivity rate currently what we have is 6.87%. From the left side, this is, I mean, the cascade, care cascade, based on the latest data, April 30, 2020. And according to this cascade, in the treatment, we have enrolled already around 69,000 of patients, and the treatment was finished in 63,000 with the very good outcome. Particularly, we reached SVR in 98.8%. Liver cancer in Georgia was, I mean, liver cancer in Georgia was the data of liver cancer was collected based on our cancer register, and here I'm presenting the data 2015-2017, where the liver cancer, I mean, the number was 458, and that's liver cancer, that's 275. Out of those, more than 1 year, I mean, the year after being diagnosed, the deaths was founded in 12%, and majority, unfortunately, lived less than 1 year. Confirmed HCV cases among those was 85, which is 31%, and enrolled in HCV treatment have been 28, which is 33% of all those. The technical advisory group was created by the Ministry of Health of Georgia with collaboration with CDC and WHO, and is comprised by leading international experts in the field and one of whom is Ms. Tatiana Reik, our great friend, and she is the member of our advisory board since 2015. One of the main, and I'd like once again to thank to Tatiana for the invitation to this distance conference. One of the main recommendations of TAC 2018 was to consider collecting data on HCC in relation with HCV. For this reason, in collaboration with CDC, was conducted a study to evaluate HCV attributable HCC. In Georgia, for this year, for for the years of 2015-2016. The HCV attributable HCC study, the primary objectives are listed on this slide. I will summarize the main objective, and the primary objective of this study were to estimate the recent HCV attributable HCC incidence, understand the limitation of capacity available for the ascertainment of HCC in patients with liver cancer diagnosis, and inform strategies for future surveillance using the Georgian Cancer Register and the Georgian eHealth database from one side, as well as the mortality register and HCV testing and treatment database from other side. The study results are presented on this slide. HCV in HCC patients. 119 liver cancer cases was analyzed, and 29% in 38 HCC cases was confirmed. In 47% or 15 confirmed HCV cases, we have investigated these cases, and 6 were reported to the treatment, and unfortunately 2 died. Future our plans for the according the recommendation of technical advisory group, particularly which took place in end of 2019 regarding HCC, was established the hepatocellular carcinoma, HCC surveillance among cirrhosis patients treated in the program. HCC treatment should be linked to the elimination program. If resources are limited, consider identifying high-risk cohorts for prioritized screening. And finally, as we all together are in the COVID pandemic environment, and how this pandemic has affected the HCV elimination activities are listed here. Unfortunately, countrywide HCV testing in this year, in 2020, has declined. Integrated testing, HIV, HCV, TB, which was like the know-how of Georgians. Also, when we on the primary healthcare level have investigated all population against 3 infection, has been also unfortunately reduced. Follow-up of identification of new cases has been also halted. Linkage to treatment has also declined. Due to these effects of the pandemic, we have to revise our targets and timelines in our new coming HCV elimination strategic plan for 2021-2025. And we hope very much that since July, we will accelerate our efforts to HCV elimination program, as we until today have quite a good achievements to not stop, but to slow down the epidemic of COVID in Georgia. And I hope very much that since July, we already will accelerate the efforts to the patch of the HCV elimination in all directions, including screening and treatment.
Thank you, Dr. Gam Krilize from Georgia. Dear participants, Professor Adriana Vince is still here, and Professor Vince will moderate this Q&A session.
Okay, thank you, Daniela. So we have heard a lot about problems of elimination, and I wish to thank all the contributors for their comprehensive presentations indeed. And now we have still some minutes for discussion. So everybody who is still with us, any questions or comments? Okay, then maybe I can a little bit of do some pushing. Maybe we haven't heard from Milan Mišković from Macedonia in former discussion. Maybe Milan, you have to say something now.
Yes, thank you very much, Professor Vince. I must say that this conference is amazing. We heard a lot of details, a lot of statistics, a lot of new research, and the new steps how we will proceed in these difficult times with COVID-19. I like to say about Macedonia some things because we heard something from our professor Victoria Chalovska. She makes small overview about the situation in my country. I must say that we have a little bit more steps forward because exactly because the government or Ministry of Health decided the past couple of months, even in COVID situation, to give us a little bit some kind of a budget, a conditional budget. We know that we still don't have on the positive list. That's one of the good news for the new therapies, multi-genotype therapies. Before 2-3 days, this procedure finished. The supply is gonna come, and I think very soon. But from my side, the overview of the situation in my country is going to be better because I must mention maybe Professor Chalovska forget that in October the Commission for Infectious Diseases make some kind of a working group with 7 participants from different stakeholders who will proceed to make some kind of action plan in our country for the next steps, how to proceed with the process of elimination. Also, one of the things which we included in this group was that we need to make a good system of surveillance and monitoring of the situation which we have it in this moment, because we know the data which was presented in the past 2 meetings, technical meetings with support of WHO, were a little bit strange because came out that we have quite different statistics or data with this kind of diseases. And my question is that no, my question, but my overview of the whole situation in my country is that it's going to be very fast and much better. I hope so that they don't want to change their mind, and they will proceed with what they promised and before the end of the year and before the start of COVID-19 situation. We know that everybody, we must update on the new lifestyle which is going on. It's going to be, I think, longer than everybody was expecting, and I hope that all the services in the healthcare will find a way how to manage open facilities and open budgets, how to proceed with the patient, which also exists in this moment, and they're going to make a big damage in the future if we don't proceed with the pressure that all other health and health problems need to be involved in some kind of breakdown with COVID-19.
Okay, thank you, Milan, for your contribution. And I also thank Katarina Alsenberg from CHIU who wanted to say something still on the topic. Is she still with us? Katarina? No? Wanted? Any?
Okay.
Yeah. Okay.
Hi, thank you very much. Hang on, start my video. Sorry, I wasn't quite clear that I had that much power to unmute myself.
Okay.
Well, thank you very much. It's been a great discussion. I mean, as Milan was saying, loads of statistics or so. I mean, it would be good to make sure that despite the COVID or such, we do move forward on the I mean, elimination of hepatitis B and C, I mean, and also the cancer prevention front. And obviously, I mean, with the European Commission focusing on cancer, I mean, with the adoption of a cancer plan in the end of this year, so obviously there's a big opportunity or so. However, I think we have a lot of, lot of brain power in this kind of conference. It's important that we now make sure that we do carry the message outside to policymakers who might not be as knowledgeable about the link between hepatitis elimination and cancer prevention as there should. So, I mean, that would be basically one of the things I would like to add to that.
Thank you very much. Any other contribution? Maybe somebody wants to comment still? Professor Hrstić, I heard you wanted to say something.
Hi to everyone. Can you hear me?
Yes, we can.
I think it's an excellent point of talking, excellent way of having that web seminar. It was very interesting to see the data from other countries and how people are dealing with viral hepatitis and HCC. Actually, I want to ask a question, maybe if someone wants to answer. How do you usually do surveillance of a patient with chronic hepatitis toward HCC? Are the patients doing surveillance and ultrasounds in their own city or just in clinics as outpatient clinic? It will be very interesting to know the point of dealing with that in other countries. Are they decentralized or centralized? Are they doing everyone in one clinical center or in different clinical centers?
Was that a question, Irena? Or?
Yes, it was a question for other countries. How are they dealing with surveillance of HCC in patients with chronic hepatitis? Are they doing in their own hospital or at community hospital, for example, in GP's office?
Well, can somebody add to this question?
Professor Vincent, are you doing HCC surveillance in your own clinic or patients are doing in other cities? Well, how do you perform surveillance for HCC?
Yes, we have a national cancer registry and we have cancer data that we fill in for every patient that comes into our hospital, and I do hope that the other hospitals are doing it as well. So those data come to our national Croatian National Institute of Public Health, who then...
But who is performing ultrasound?
You mean who is doing it? Ultrasound is being performed by specialist radiologists at our center. Yeah.
In a hospital where patient live, for example, in a city where patient lives?
Yes, in a city where a patient lives. I don't know for every city, but mostly it's been done in their own cities. They don't travel for ultrasound to some other city.
Okay, because there was a tendency while ago that the patient needs to perform surveillance just in clinics, not in another hospitals, not in a different hospital, just in the clinics who are specialized for cancer, for example.
No, I think ultrasound specialist radiologists can do this job quite good in Croatia, I believe. So I don't think there should be any traveling to other cities to have. I mean, a good ultrasound performance is standard of care at the radiology department in all hospitals. Maybe I misunderstood you, but yeah, that's my...
If I can to make a completion from Romania?
Yes, of course,
It is a patient perspective. The situation I think is similar with Croatia situation. of course, if the hospital have capacity, you know, depends of the town, also in Romania. And of course, all the data are do it to the gastroenterologist or to doctors to, you know, to say the final results. I agree with you, is a similar, depending on the hospital capacity.
Okay, thank you.
Yes, but in the surveillance, the problem is we have realized once you find hepatocellular carcinoma in other clinics, they usually don't test for viral hepatitis markers. This, I think, it's a problem in many countries. So we don't really know the disease burden connected to hepatitis B or C. So those data are kind of tricky, not strict enough. Yeah, but I think that's the problem everywhere. So I think the clinicians should be more aware of the fact that not only they should look for hepatocellular carcinoma, but they should always do the viral hepatitis markers. Okay, any other comments? I think we are a little bit exhausted here, so I think we will conclude with this part of our session. And as this is a high-level meeting, I was told by the organizers that we should conclude with a draft of recommendation that have been drafted from the organizers and myself. And there are recommendations that we plan to send to European Commission. So as we are running a little bit late, I will not go through those recommendations, but we will send you written form of it by email to all of you, to all of participants, and we kindly ask you to give us your feedback in next 10 days, then we can proceed and really make those recommendations work and send them to people who should read it and really can do something about all the problems we were actually stressing today. Okay? Any other comments to this, or is this fine by you? Okay. Okay, so thank you very much on behalf of myself and the organizers and all the presenters and speakers. And we will continue at 4:15. So until then, bye-bye.
Bye.
Bye.